Okay. Good morning. It's a privilege to talk in this meeting. I think many surgeons do not appreciate how frequent they take decisions in uncertain conditions. It's true that even in complex cases, most of our decisions are based on vast experience and knowledge, but there are at least 15-20% of cases where the decision is based not on real knowledge. And when you analyze it, you see that many forces, sometimes unclear, influence your decision making. And just to embark on the proper atmosphere, I'll provide you with few examples of cases, routine cases from the last couple of months in our Department of Surgery that will simply show you how often you run into decisions under uncertain conditions and what influences on this subject. So we'll start with the first case. It's a 78-year-old woman. She has a carcinoma of the rectus sigmoid, and she underwent anterior resection of the colon with a stapled anastomosis. Everything goes very smoothly. However, on the second post-operative day, she develops distress, disorientation, very mild. She's a bit tachycardic, moderate fever. She has distended abdomen, mild tenderness, not more than that, no overt peritoneal signs, mild leukocytosis, no acidosis, pneumonia and gastric dilatation are excluded. The differential diagnosis is very clear. She has probably suspected an anastomotic leak or some other diagnosis, quite common, that may lead to this picture. And should we operate or continue to follow? Non-operative approach. The order was selected according to the voting. So the fact that we present a non-operative approach first does not mean that this is the primary option or the reverse one. Non-operative approach, there are no signs of overt leak or peritonitis. The signs could be secondary to surgical trauma, anesthesia, telectasis, paralytic ileus, very easily. Even if it leaks, conservative approach may be legitimate for a localized leak. The infection may be organized and become suitable for CT-guided drainage. Should we do abdominal CT? It's funny, people usually hesitate to give a cup of tea to such a patient, but they don't hesitate to give 3 liters of contrast material and blow the abdomen, even with the knowledge that leakage is demonstrated in only 50% of CT under these circumstances. Also, unnecessary reoperation in such an elderly may be risky, and let's wait for more solid evidence. Please vote. Okay, we'll go on. Sufficient time? Okay. How about operating this patient? I think we better wait to the end of the case, okay? Please. How about operate on this patient? Are there good reasons? Maybe. Leak and intra-abdominal sepsis is very likely. Overt signs of peritonitis are infrequent in the elderly. Ongoing peritonitis and sepsis is life-threatening in such a patient. and the risk of negative exploration is negligible relative to misleak and ongoing sepsis. Please vote. You can change your mind. You can vote against an operation at the beginning and for an operation afterwards. It doesn't matter. Okay. The patient was operated on. This was the selection under these uncertain conditions, pro and cons. Fecal generalized peritonitis was observed with gross anastomotic leak. She made it. Okay? Let's see the results, please. Okay. Okay. Wow. Operate? Nobody. Nobody? No. It was a technical error. It was good excuses. Good excuses. Okay. 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 So let's move to the next case. Okay? It's a 64-year-old woman, very obese. She has diffuse abdomen. She has signs of appendicitis. Let's cut it. She has tenderness, she has peritoneal signs, she's tachycardic, and she has significant infection, 25,000 leukocytes. And on CT, nobody can make nowadays a diagnosis of appendicitis without a CT. Okay? So the CT demonstrates thickened edematous appendicitis with fecalate at its base and significant periappendicular infiltrate and no abscess formation. Patient is quite sick. She's markedly obese. She has orthostatic sleep apnea. She's atherosclerotic. She had ephodyspnea. She has hypothyroidism. She's status post cholecystectomy, and she suffers from depression. She is prepared for surgery, but during preparation, an ECG is naturally taken, and she has significant changes. She has inverted T waves. The troponin is 19,972. The upper limit is 5. The upper normal limit is 5. So it's markedly elevated troponin, suspected acute myocardial infection. She has cardiac echo and coronary angio, and it's very obvious. Look at the very impairment and desynchronization of her heart, impairment synchronization between the left ventricle and the apex. And it's a typical syndrome called Takotsubo syndrome, okay? It's similar to acute myocardial infarction. It's equivalent, at least in risk manners. And attending surgeon and a cardiologist discussed the case over the phone. Conservative approach. Anesthesia and surgery during acute MI are risky. Mortality exceeds 5%. It's very serious. And conservative approach for appendicitis is legitimate and quite established nowadays, especially in children, but maybe also in the elderly. Please vote. Okay, operate. What are the reasons to operate on this very risky patient? The infection is very significant, 25,000 leukocytes to start with. The obese abdomen is unreliable for peritoneal signs. The presence of obstructive fecality at the appendix base makes it unlikely that the infection will resolve. Takasubo syndrome and type 2 MI are typically due to stress, pain, and sepsis, and ongoing or worsening of the infection is more dangerous to the heart relative to a single surgical intervention that stops the infection. Please vote. A conservative approach was chosen. However, after a few hours, the patient condition worsened, namely pain, fever, more leukocytosis, and she was operated on. A perforated appendicitis with peritonitis was found. An appendectomy was performed, and the post-operative course was very smooth. One short elective case. Okay, this is not necessarily decisions under uncertain conditions are not necessarily in acute cases. They are also very common in elective cases. So it's a 37-year-old man. He's a web designer. He was a professional kickboxer, a huge man, okay? You know the sport. Some people call it a sport. So he's obese, he has impaired liver function test, suspected fatty liver, and therefore he undergoes ultrasound of the abdomen, and a mass is found in the abdomen. CT demonstrates a large retroperitoneal mass, mostly cystic, with some calcification in it. It's retrocaval. It encases the right kidney hilum, and it erodes the vertebra, okay? The differential diagnosis is between the organized hematoma, all the hematoma secondary to his habit of getting kicks, or a tumor, a sarcoma. A CT-guided biopsy is performed. Only fibroblast, collagen, lymphoplastic infiltration, macrophages, blood is demonstrated. What's the decision? Operate or follow-up? Non-operative approach, okay? It is likely that the lesion is an old hematoma. The operation is major, potentially with significant mortality. Close follow-up will enable to detect changes indicating tumor, and then we can perform the operation. Pathological confirmation is recommended or may be mandatory prior to elective cancer surgery. Some surgeons believe this is the case. Please vote. Okay? Why operate? Malignant tumor cannot be excluded. Biopsy is actually reliable only when malignancy is established. Otherwise, it may not represent the real pathology. Watchful waiting may miss the therapeutic window. We just heard from Alessandro Bonci that we can cure some 50% of cases with retroperitoneal sarcoma. If this patient has only 20% chance of a sarcoma, we may, lose this 10% chance for cure on this patient. Only 20% chance of sarcoma. So what should we do? Please vote. Can we see the verdict? Okay, very interesting. 14% changed their mind during the discussion. Okay, it's only demonstrate the importance of risk-benefit calculations. Okay, we operated on the patient. He had a large retroperitoneal tumor, retrocaval encasing the renal hilum. En-bloc resection was performed with the right kidney, pathology, peripheral nerve sheath tumor, soft tissue sarcoma, disease-free at 3 years of follow-up. Okay, so this was only a short introduction to a very complex issue of decisions under uncertain conditions, and I would like to ask Dr. Eran Nizri and Nahum Bagleiter, who agreed to discuss this very complex issue, and they'll do it together. Please.
So, good morning, everybody. On behalf of Nahum and myself, I want to thank Professor Clousner and the organizing committee for the possibility to present our thoughts here in this lecture. And just to get into the appropriate mood, I would like to start with some thoughts about boredom. Max Weber was an eminent social scientist who acted in Germany in the beginning of the 20th century, and he diagnosed boredom as one of the main problems of the modern society. And this is because as science and technology advances, we know more about our surrounding environment, and the world becomes more calculable and more predictable. And things that were once thought to be mystic and with a kind of charm are now predictable, and this causes boredom. So in this aspect, I think that the uncertainty in surgery may be a route for interesting and for things that are not boring because we don't know them. They are unpredictable. This is what makes our profession so fascinating. So if we think about the extent of the problem, as Professor Clousner presented some cases, we see that we can encounter uncertainty in every aspect of the treatment. We see it from the diagnosis. Even though we have very sophisticated imaging modalities, we still operate on some patients without definitive diagnosis. We don't know which treatment to apply, whether to operate some patients or to take the conservative approach. When we do operate patients, we have doubts regarding the surgical approach, whether it's minimally invasive, which devices to use. And things are worse when we tend to combine different surgical modalities like chemotherapy and radiotherapy. We are on uncertain conditions. And regarding outcomes, many procedures that we make, we don't know enough about long-term outcomes and about patient-centered outcomes. And all this uncertainty, it continues to evolve because we are living in an environment of continuous change. Even things that we think that we know or we knew in the past are questioned and doubted due to new research. Like Professor Clousner mentioned, we have now questioned the dogma of operative treatment of appendicitis. And also there are questioning the common practice of making a Hartmann procedure when you have perforated diverticulitis due to new data that is accumulating. So we may actually say that uncertainty is here to stay, and it's almost an existential state. Now, if we want to know how surgeons make decisions in phases of uncertainty, we have to know how humans in general make decisions in the face of uncertainty, and how do humans think in general. And I will just show this Venn diagram to show that even surgeons are humans.
Kind of humans. Thank you, Eran. Now, in the middle of the 20th century, mathematicians, psychologists, and economists defined a new subspecies of the Homo sapiens called Homo economicus. And the Homo economicus acts in perfect rationality and has only two goals in life. One is to maximize gain, and the other is to minimize losses. Are we, the Homo medicus, do we share those virtues? Well, we all worship evidence-based medicine, and we saw it yesterday and we saw it today all the time. We all use consciously or unconsciously decision trees, simple decision trees like this one with a yes or no answer, or a little bit more complicated, probabilistic one, in which every probability that appears in every branch here is generated by evidence-based medicine. And what I would like to spend a couple of minutes now and describe to you something new, maybe to most of you, the Markov chain. And the Markov chain model has, it is an enormous tool to predict and to decide about situations which fluctuate. Because many of our situations, like in my profession, in obesity or in cancer, the patient fluctuates during time. He may be, and the simple, I'll get to it later on, I'll show you an example, but the simple model is that somebody is sick, you do something, he can be healthy, he can stay sick, and when he's healthy, he can become sick again, and of course, they can all, you can die. Now, you have the probabilities of every one of these transitions. You have your transition matrix, and of course, from dead to become sick, it is zero unless you're, or healthy unless you're Jesus Christ, and dead to stay dead, the probability is 1. Now, what happens over time? The essence and the great value of a Markov chain is that it enables you, by a simple mathematic procedure on that matrix, which we constructed, to see what will happen in a week, in a month, in a year, according to how you define your time cycle, and it goes like this. So you see, this is the matrix, the probability in the matrix, and those are cycles. And let's say you stop here, and you know what is going to be after a cycle, after 2 cycles, after 3 cycles. And you can see that it is used lately in bariatric, in rectal cancer, in renal disease, and in general surgery. And the point is, when a thing can recur and can go and fluctuate between situations, like if I'm operating on a morbid obese with diabetes mellitus, he can become lean without diabetes mellitus, he can become lean but stay with his diabetes, he can lose a little bit of weight, still stay morbid obese, but don't have the diabetes anymore, and all those in-between transitions. And then you have a very complicated 5x5 matrix, but to make things simple, this is not the shower. We talked about him this morning. It's another shower. And what comes out is that using that Markov model, you can see that if you operate on a 45-year-old with 45 BMI, this guy or lady will gain almost 7 years of life. Markov model. But on the other hand, if you go and you operate on a 60-year-old with a 60 BMI, you're going to gain nothing, maybe even lose. So this is for rationality and the decision trees and Markov models. But is it so? Is it really so? And those 2 Israeli gentlemen, Professor Daniel Kahneman and Professor Amos Tversky, Zichrono Livracha, they shattered to pieces our view of rationality and of rational decision-making in the 70s and in the 80s. And Professor Kahneman won the Nobel Prize in 2002. And unfortunately, and this is the tragedy, Amos Tversky died 6 years before that time from metastatic melanoma and didn't win the prize. And may this lecture be some tribute to his blessed memory. So what they said actually is decision-making is inherently flawed by heuristics and biases. We all know we all know what biases are. What are heuristics? Heuristics are mental shortcuts, not always precise, not always accurate, but always fast, and they help us to decide. Now, and the point is that Kahneman and Tversky showed that they are very, very deeply rooted in our mind. I think because they have some evolutionary advantage. Of course, when you are a hunter-gatherer and you are chased by a beast, you will not construct now a decision tree or a Markov model to decide whether to climb the tree or whether to run as fast as you can, or to just drop down and play dead. If you'll do that, you'll be dead. You must use intuition and heuristics. And we use heuristics on a daily basis. We call it in other names like rule of thumb, educated guess, intuition, common sense. And let me give you two examples, two classical examples. The one is the Linda problem. Think about it. Linda is 31 years old, single, outspoken, and very bright. She majored in philosophy. And as a student, she was deeply concerned with issues of discrimination, social justice, and also participated in anti-nuclear demonstration, which says that this, this was constructed in the 70s. Today, maybe we would say that she is graduated from Berkeley and was engaged with the BDS, God forbid, movement. So now, which is more probable? And this question was put in front of postgraduate Princeton students. Which is more probable? And think for yourself. Linda is a bank teller, or Linda is a bank teller and is active in the feminist movement? Those were the answers. 90% said that Linda is a bank teller, is inactive in feminist movement, and this, of course, is not true. If you know very simple probability from high school, you know that this is not true. This is not the right answer. So what happened here? What happened here is that the representative heuristic kicked in, and representative heuristic says simply, like goes with like, and I don't care about mathematics. Other example, a bat and the ball. The bat and the ball together, they cost $1.10. The cost of the bat is $1 more than the ball. So what are the cost of the two items? Think about it a little bit, and the answer, which most of us will give, is the bat is $1, the ball is 10 cents. That's not a case, okay? That's not a case. If you do simple mathematics of elementary school, you see that the bat is 1 and 5 cents and the ball is 5 cents. What happened? Availability heuristic kicked in. Availability heuristics is talking about we think and we decide according to what is available to us, to what is immediate, to what is fast, regardless of mathematics. So intuition defies rationality. Now, the third element in their theory was the prospect theory. And you can see here, you can see the psychological value, and this was done empirically. I mean, it's not philosophy. It was done empirically. Nobody gets a Nobel Prize for philosophy. And you can see that the effect of losses, we are more sensitive to losses than to gains. In other words, we are more sad to lose $200 than we are happy to gain $200. So they coined the phrase that we human creatures are loss averse. Okay, so we talked about representative heuristic. Let me give you a nice example. This was done with a registered nurse, well-trained nurse in the ER, and they were given vignettes, stories, little stories of symptoms. Somebody comes with symptoms of acute MI, chest pain, sweating, etc. 100% of the nurses diagnosed them as acute MI and called the internist. Now, when a small piece of information was added that except for chest pain and sweating, the guy lost his job lately, almost 30% of the nurses diagnosed as anxiety, and instead of calling the internist, called the social worker or the psychologist. Let's go to Angelina Jolie. This is the third time We are showing Angelina Jolie. It was used twice yesterday. Okay? Angelina Jolie said, my mother fought cancer for almost a decade and died at the age of 56. Okay? Again, availability heuristic. What comes to mind? My mother, extremities, she died. It is something emotionally charged. And if it's emotionally charged, this will affect my judgment. Now, of course, it causes an increase in patient interest in prophylactic surgery. And then she says, my chances of developing breast cancer have dropped from 87 to under 5%. A new bias, the anchoring bias. Now, those numbers are now the anchors. And whenever you will think and you will want to decide what to do with such a case, you'll have in your mind the 87% and the 5%, no matter if it applies to your case or not. So this work, this piece of art, was not done by psychologists. It was done by the Veronesi group and the Istituto Mori in Milan. Now, overconfidence, zchichut, we don't have to talk about it. Framing effect. Framing effect is very important. Framing effect says that you will decide according to how the problem is framed to you. How is it described to you? So if the mortality risk in a procedure is 10%, you say, I'm not going to do it. I'm not going to do it for 10% mortality. But on the other hand, if it is framed in a way that the survival rate in this procedure is as high as 90%, you will say it's a perfect procedure, we're going to do it. Now, if you think that the framing effect affects only laymen or patients, you're damn wrong. The great Amos Tversky, and it was a delight for me to see him in New England, 82, the great Amos Tversky showed empirically on 424 physicians that physicians are affected by the framing effect in the same way that laymen are. Loss averse. One case from my clinic, an 11-year-old, bright, charming girl with a BMI of 50 with severe sleep apnea. She is on a CPAP. She has now, at the age of 11, diabetes mellitus. She's isolated, and her mother, her pushy mother, says she's going to die on me because of that sleep apnea. So to sleeve her or not to sleeve her? So I'm putting myself now on the Kahneman-Tversky graph, and I look at my losses and at my or her gains. So this is also a good demonstration of shared decision-making. Iran will talk about it later. So, and I'm saying to myself, okay, she, on one hand, she will be lean, she won't have diabetes, and she will have a lot of friends. But if that 11-year-old lady will leak on me, I won't be able psychologically to handle it, so I'm reluctant to operate. The mother, on the other hand, from the same loss-averse attitude, says, no, she's going to die because of the sleep apnea, and she pushes to operate. Now, to finish my part of the talk, I want to just to show you something which blew my mind. A group from Beersheba published in the PNAS, a very good paper, and they asked themselves, what about the saying that justice is what the judge ate for breakfast? So they looked at parole judges who has to release detainees al tnai, b'shichurim al tnai, and they saw something amazing. In the morning, when the judge comes to office and he's well fed after a good night's sleep, he was kissed by his wife probably, and he comes smiling, the good guy, and you see that the proportion of favorable decisions, the rate that he releases is here. But then after a couple of hours, before lunch break, he's tired, he's hungry, he's frustrated, and releases drop down to 0. Okay? Human's life. This guy are judging about human's life. Now he eats a little bit, he chats a little bit with his friends, he comes back, and then again he's the good judge. And then again, the good judge, 4 o'clock before the 5 o'clock tea, is again the bad judge. You're laughing. Some people are crying because of this. So this is shocking. Now, are we surgeons better than professional judges? Aren't we deciding according, are there many factors, according to what my boss, and your boss can be your boss at work or your boss at home, what will say my boss? Or how will I be appreciated by my colleagues? Am I going to be conceived as a coward, or am I going to be conceived as a macho? Do we decide the same during the week and during or before weekends? Think about it. The answer is no. Now, what about what is the impact of burnout on our decision making? So we have on one side rationality and models and things which go by the book, and we have on the other side biases, ethics, family. I want Iran to do some order in that mess.
So just to summarize the things that Nahum mentioned earlier, so Kahneman and Tversky actually divided the mental system of humans to two systems. The first system is called System 1. This is the automatic system, the fast system. The system just gives you answer even if you don't ask it to. They give you a lot of information all the time. And this system contains the heuristics and biases. And as Nahum mentioned, maybe it had some evolutionary advantage. But in current life, it gives you all the heuristics and biases. And the intuition is part of this system, which can also not be trusted too much. And System 2 is actually the system that you should rely on. It is more slow. It is mentally, it demands a mental effort. You have to stop and think about it. You have to calculate. We tend not to do it. Kahneman calls it the lazy controller. And this system contains the rationality. And in this system, we actually make the rational decision-making using risk, benefits, and models. And you should always try to resist the temptation to adhere to your System 1, like in the problems of the bat and the ball and the Linda problem, which gives you the first answer, and go to the System 2 to get a more reliable answer. And we would like to think the surgical decision-making is a System 2 process. And now let's look into this hypothesis. So we actually encounter complex clinical decision-making in several instances. One is the preoperative management in the decision to operate, yes or no. But we know that we make a lot of complex decisions during operations. And as Frank Spencer said once, that a skillfully performed operation is 75% decision-making and only 25% dexterity. And Professor Cloudner says that it's 90% decision-making. Now, we're not going to speak about preoperative management or post-operative management, but let's focus on the decision to operate. So this group actually looked at the decisions to operate and tried to prove that there is a connection between surgeon judgment and perceptions of risks and benefit and the decision to operate. So we know that there's a lot of variation in the use of surgery between different surgeons. For the same case, different surgeons will decide differently. And we know that the decision to operate is a core surgical capabilities. We try to train our residents, and we think that it's very important. The decision to operate is dependent on judgment. So is the decision to operate influenced by risk-benefit analysis? What they did in this trial, they gave clinical vignettes to surgeons, and they asked them to evaluate or to estimate the operative risk and the operative benefit. And these are common clinical scenarios that we encounter in urgent surgery, like mesenteric ischemia, gastrointestinal bleed, etc. And you can see that there's a large variability in the operative risk estimation given by surgeons. It's almost a Gauss curve. See that some surgeons estimate the risk as very high and some is very low, and the operative benefit is the same. There are cases in which you see more homogeneity. And when you look at the decision to operate, again, you see a large variability. There are some surgeons that will operate, and there are some surgeons that are very unlikely to operate. And again, there's a large variability in these cases. Now, what's important and what the good news is that there's a correlation between the judgment and the estimation of risk and the decision to operate. Meaning that if a surgeon estimates the risk of the operation below the mean, he would tend to to recommend more on operative management. Whereas if surgeon estimate a risk to be higher, he would not recommend an operation. So these are the good news. And there is a correlation between our judgment and our recommendation. So suppose that this is the case if we gave surgeons a calculator or any objective tool to predict risk, then we would estimate, we would suppose that the heterogeneity, clinical heterogeneity will decrease, and the recommendation to operate will be accordingly connected to the risk estimation. So in a later work, the same group from UCLA tried to give surgeons a calculator, a risk calculator, which is a validated one and extensively used in the US. And they try to see if the risk estimation affects the decision to operate. So this is a randomized controlled trial in which there's a control group who was asked to estimate the operative risk without calculator, and the other one which was exposed to the calculator. And as you can see here, the gray bars here is the control group, and you see the variability that we spoke about in the first place. And this red dot here is the value given by the calculator. So you see here that the group that was exposed to the risk calculator tended to be less heterogeneous, and the risk estimations are near the value given by the calculator. And generally speaking, the risk calculator reduced the risk estimation of the operation to the surgeon. So in light of this finding, you would think that if we have a tool that helps us to know that we have the operation is less risky, then we'll get more operations. But this is completely not the case. The rates of the recommendation to operate were the same. Both groups recommended surgery at the same rates. Now this is surprising. What happened here? When they looked into the data, they saw that the control group indeed estimated the risk, operative risk, higher than the risk calculator group. However, the risk calculator group, although not given any data regarding the non-operative risk, decreased also the risk estimation of the non-operative risk. And this is the anchoring effect, in which you give a number to the surgeon, you say to him that the operation is less dangerous, and he applies a bias and decides that even the non-operative risk is also lower. So these are the fake news, actually. And if you think about this closely, you see that this large variability in the operative risk, when you ask a person to make a risk-benefit calculation, when this large variation, I think it's a little bit too optimistic to think that every different surgeon read a different series in the literature and the numbers come from a variability in the literature. I think that it is more logical to assume that some of the risks are part of the availability bias. Some people remember the last case, they remember the extremities. Some may represent the loss of avers, and etc., and representative bias. So we see that the process is not perfect. The process of clinical decision is not perfect. Now, there are some limitations to this type of work. First is the use of clinical vignettes. We know that they do not encompass all the factors that influence decision. We don't have the very meaningful encounter between the patient and the physician. It may also be that what we see here is reverse causality. I mean, people are asked to estimate the risk, but maybe they decide even before they estimate the risk. And this is a general notion about measurement the process which changes the process, like this type of decision making. When you ask surgeon to estimate the risk and then to estimate the non-operative risk, then you actually may change it because people may not do it in real life. So if the process of decision-making is not perfect, what we want to suggest that we need to open it, and we need to combine other people's experiences or biases and consult our peers and ask them for their advices. And you should remember that when you communicate an uncertainty, you have to formalize it in language that you can pass to another person. You have to make it in a rational way, and you may have to justify your case or your appeal. And it is also true for the accountability. When you know that you will have to stand in a morbidity or mortality operation meeting and you will have to describe what you did, you know that you cannot say that I decided it because it felt to me the right thing to do as a gut feeling. Another aspect of sharing the decision is with the patients, is to ask the patients what do they really like. And it's not only true when we don't know, there is not enough clinical data to recommend a clear recommendation, but it's true also for clear cases. It's always important to know what the patient wants, and you don't have to construct a decision tree model to know what the patient wants. You just have to have an empathic conversation between patient and physician. Now, much of the work Kahneman did, which tended to under-evaluate intuition as a decision-making tool, was done on political scientists or commentators and brokers. Kahneman likes to cite a research in which they took 100 of the biggest, of the CFOs of the biggest companies in the US, and they asked them for 8 years to predict the stock market and the stock performance of their own company. And the correlation was nearly 0 for 8 years. And these are very skilled individuals, very intelligent individuals, and they could not predict what their company will make or the stock market. So he had a very bad view of intuition. But there are other voices in cognitive psychology, like those of Gary Klein, which actually analyze firefighters and pilots and nurses, ER nurses, and he came to different conclusions regarding intuition, and he thought that intuition may be a very good tool to make decisions in the experts. And the question is, to where do we belong as physicians? If we belong to the firefighters or the combat pilots, or do we belong to the brokers? And what's interesting to note is that Kahneman and Klein actually collaborated. They had a scientific collaboration for 8 years, in which this was the question that they asked, is when can we trust expert intuition? And they published a paper which said conditions for intuitive expertise, a failure to disagree. So they agreed on these 2 conditions. And they said that you can trust an expert intuition if it fulfills 2 conditions. First, the environment has to be sufficiently regular to be predictable. The stock market is not a sufficiently regular environment, and you can never predict it, and no matter how much expert you are. And the second thing, which is an educational call, to my opinion, is that you have to have the opportunity to learn these regularities for prolonged practice. And this is a very important thing. You develop intuition with your experience. And you can think about it in terms of a rafter which goes to the river, and due to his long practice, he knows which streams he can avoid and how he can avoid rocks, and this becomes intuitive because he practiced about it. And I want Nachum to elaborate more on this.
Thank you. This is going to be the last switch. So Kahneman and Simon asked themselves, how do chess masters, they play simultaneously, they have less than a second to look at the table and to decide what to do. So they say that the situation has provided a cue. It provided a cue to them because they are so experienced. It will say nothing. There will be no cue for me or for other mortals. This cue is given the expert an access to information. The information, of course, is stored, the memory, in system 2. And the information provides the answer. Intuition is nothing more and nothing less than recognition. Now,
Cactus 1549, 700, landing at 5,000.
So now, Raoul knows it by heart. Captain Sullenberger is taking off from LaGuardia with 155 patients on board. This is a typical Freudian slip. 155 passengers on board, and a couple of seconds later, the plane hits a flock of very angry Canadian geese, and he loses both his engines, and he starts to dive. Now, he has big problem. He has to evaluate the situation. He has to look at options. He has to decide what to do, and he has to execute his decision. And in the time, roughly the time I'm standing here and telling you this story, he decides to land on the Hudson, and by that, he saved all his passengers. Nobody became a patient. And I want you to listen carefully. עכשיו תשימו את הווליום בבקשה. מה זה? And I want you to listen carefully to what Sullenberger has to say about his decision-making process.
Well, there were a lot of choices to make. I mean, if we were to go over that flight again, it would, and I've done this many times, so I know it would literally take me about 10 minutes to describe what happened in the first seconds, because of all the things that I didn't have time to consciously think about, but that were in the back of my mind, that were immediately accessible to me, so that helped me frame this decision, frame these choices.
So what he said, I didn't have time to consciously think about it, but I had it in the back of my mind. I have experience. I have a pattern recognition. I'm aware to the situation, and it was immediately accessible to me. So when an expert is making his decision, he is on that continuum, on that cognitive continuum between system 1 intuition and system 2 analytical, and what happens when he does his decision under pressure. So under pressure, we tend to move more to system one, but the system one for the expert is different. He has situational awareness, he has his cues in the situation, and pattern recognition, but pattern recognition is something which is stored in his memory in system 2, and actually he uses simultaneously system 2 and system 1. Now, Apollo 13, 55 hours into the flight, at the distance of more than 320,000 kilometers from Earth, Captain Gene Lovell utters what becomes to be one of the most known phrases in human history: Houston, we have a problem. Now, I want you to listen carefully to what the great Gene Kranz, the flight director, has to say about decision-making at the few last seconds of the clip. Volume.
We had an explosion with an enormous amount of corollary damage.
In fact, they came to learn Apollo 13 had suffered a catastrophic failure. There was faulty wiring inside liquid oxygen tank 2. When Jack Swigert stirred the tank, a spark started a fire, fueled by pure oxygen. The tank blew up, taking out the ship's main supplies of air and power. But Gene Kranz knew they all had to start making some decisions, and fast.
I was a fighter pilot. Fighter pilots in my time used the words looking into the eye of a tiger. And this was the feeling I had when I recognized we were in survival mode and we had to kick in and get going as a team to help this crew out.
Now, another decision loomed. How to get back to Earth.
I had a very fundamental decision I had to make. We could execute what we call a direct abort and come around the front side of the moon and be home in a day and a half.
It was the quickest way home, but it would mean using the main engine, the one nearest the explosion. What if that engine failed, or blew up as well?
If this maneuver isn't executed perfectly, you're going to impact the moon.
If the spacecraft would actually go right into the surface of the moon?
Yeah.
Kranz didn't want to take the risk.
The other option, I'd have to go completely around the moon, take between 4 and 5 days to get back home.
The problem with that was obvious to the astronauts themselves.
When we started going to the lunar module, I realized it was designed for 2 guys for 2 days, and I counted the crew, 1, 2, 3 guys for 4 days.
Simple arithmetic that meant they could run out of air, power, and water long before reaching Earth. In the end, it was the flight director's decision.
And it was purely in a gut feeling that says, go around the moon, take your chances, trust your team to find the answers.
What did he say? Gene Kranz. I was a fighter pilot. I have experience. I immediately recognized that we are in a survival mode. My situational awareness and pattern recognition. But what is shocking, he said, and it was purely a gut feeling saying go around the moon. Gut feeling. Now, in our daily experience, we have to make choices between, let's say, something, should I buy or not a Da Vinci robot for my service in Mount Scopus? Totally system 2. On the other hand, when I have something like clinically urgent, a bleeding spleen during a laparocolectomy, whether to use simple measures like hemostats or to do a splenectomy, and when doing a splenectomy, to open, to stay laparoscopically, time pressure is high, human factors, a lot of system 1, and a little bit of system 2. So, what if you are not such an expert, and you don't trust your own gut feelings? Let's say when you're a novice, or when you face something very, very complicated, which you see for the first time of your life. So we go back to Pirkei Avot, to the ethics of our fathers, of our sages, which said, assume yourself a master and acquire yourself a friend, which we can see also as assume yourself a mentor and acquire yourself a peer. Now, mentors or expert opinion in the culture of evidence-based medicine is almost conspicuous. But sometimes when you run into trouble in the operating room, this is the thing you need most of all. Socrates, couple of centuries before our sages, said, "Know thyself." And there is starting to be evidence in the literature that improving our decision-making is about awareness of the biases and the heuristics, which we talked about it previously. Maybe knowing about it consciously will permit us to avoid being influenced by them. Another strategy is put forward by David Casaret, New England, a couple of months ago, when he said that maybe we have to forcefully adopt what is called, quote-unquote, conscious heuristics against those subconscious heuristics which influence us so much. And he gives a couple of examples. I'll give you only two. He says, if you see evidence of success, look for evidence of failure. If you have a patient who is septic, and on the other day his white blood count drops from 20,000 to 18,000, and you say, okay, he's starting to be good. No. Look for evidence of failure, and this is against the confirmatory bias. And before you conclude that the treatment was effective, look for other explanations against illusory and overconfidence. So, if I want to wrap up everything, our 35 minutes, we are on time, you'll see. We'll say that surgical decision-making, the process, is not a linear process, and it is influenced by many, many factors. And our take-home messages are work within structured models, whether it be a decision tree, a risk calculator, Markov models, for instance, but you should know the limitation. Be aware of common subconscious heuristics and biases, and once you know that they exist, you can try and avoid them. Adopt some conscious heuristics, use others' experience, mentors and peers, share your burden with the patient, go and see 2 movies, both of them with Tom Hanks. And actually, the guy who won the Oscar for Apollo 13 is Ed Harris, who played Jim Krantz. And read only 1 book. Thank you.
This is naturally a heavy topic, so we have a heavy panel. Okay. Very interesting. Thank you again for this brilliant lecture. Thank you. Not according to our real material subjects, gastric cancer, what to do, another language. Thank you. It was brilliant. My first question to the panel after this lecture examples, is it going to really influence your decision making? Even a bit? Ben Shimon. Okay. After this long lecture, plenty of ideas, data. Is this really going to influence your decision making in the next case? You'll have to decide.
Wow. No, it was a brilliant lecture. With the time, with the experience, more or less, I am more and more convinced that we know that we don't know. And it's a very important thing that we have to know that we are touching the heart of our practice. And the heart of this practice is to remind us that what we are doing is dealing with human beings, and we are also human beings. And with the large amount of knowledge that we have now, it's very difficult to make a decision without taking in our mind all the other factors that we saw. That's the reason why the sentence is very true. Our job, medicine and surgery, is not an exact science, but is an art. And when we say that this doctor is a very good doctor, this surgeon is a very good surgeon, I think that we were all trained in the same universities, and if you take 100 surgeons trained in the same school, they should be the same. And they should be the same surgeons giving the same care to the patients. But not, it's not the real life. The real life is because they are doing the art differently. And maybe they are good doctors or good surgeons, and the reputation of this one or this one is because they have a knowledge, there is a balance with the knowledge and the way they use this knowledge. And I think that, of course, we have to be aware of the decision can be changed. And it's very interesting what you did, Professor Clousner, because we saw that at least 15% of the audience changed the decision in 1 minute. And we can change the decision. And this is maybe also the intelligence of the surgeon to be able to change the decision.
Very interesting. So you think it's knowledge or really personality and ethics? Jeff?
I was struck by the comments on pattern recognition, because I think that's really what we do as surgeons, both in our decision-making clinically and in the operating room. And so many times the errors that are made, I think everyone in the room has probably done a hard gallbladder operation, and we struggle, and there's scar tissue, and then we see a tubular structure. We say, we found the cystic duct. Thank goodness. We relax. And I thought the slide that was shown at the very end about, instead of sort of celebrating your identifying what you hope you see, that's the moment to actually say, wait a second, maybe that's the common duct or the hepatic artery. And I thought that was very useful, and I probably will try to take that with me.
But would it, I mean, will all this information change your decision analysis?
Well, I think the idea about, I think hopefully it's what I do already, which is to stop and be careful. Okay. Which ultimately I think is what we all have to do as surgeons.
Okay. Mitch?
Yeah, I thought the lecture was wonderful. And I agree with Jeff. I don't think that it changes how I think. I think it confirms what I deal with on a daily basis. You talk about Pirkei Avot and ethics of our fathers. I always tell my residents, think about what your mother taught you and you'll probably make the right decision. And I think we struggle with these issues on a daily basis and in the operating room on a minute-to-minute basis. And I do think we have to always fight confirmatory bias, because that is really sometimes what sends us down an improper pathway. And I think the lessons that I've learned over time, and I think were validated here, is one that it's always right to ask for help and to get another person's thoughts about whether you're thinking correctly or incorrectly, or there is no right answer. I think that's the same because when we deal with morbidity and mortality conference, for some people who are MIS surgeons, converting to open is a sin, and I see it as, in fact, more than likely the right decision if you've even thought about it for a moment. And then the other issue, I think, is the issue of experience. And I struggle with that also on a daily basis as I've seen how we've limited our residents in terms of their experience, in terms of work hour guidelines and other issues. And you have to balance that against the issues of burnout, where I do think you can make conscious decisions that are not reflecting what may in fact be the right decision. So I think you're balancing these issues on a daily basis all the time.
Alessandro, I want to ask you, in your team, could you anticipate, you know your team, okay? Could you anticipate on a given surgeon, what will he decide in uncertainty?
Not in a scientific way.
No, but in a precise way.
Yeah. I mean, it depends to which extent you know the people you're working with. Yes, in fact, I can do that. Yeah, and also I can predict the one who will call somebody for help and those who will actually try to solve the problem on their own.
So you really imply it's a personality problem? It's a personality issue? I mean, if you could anticipate who will decide this way, who will decide to operate, who will decide to be conservative, I mean, you know something that maybe we cannot quantitate, but it's really solid knowledge.
Yeah, I mean, I don't know whether I call it solid, but in fact it is what it is. I also enjoyed the lecture a lot because, and what I really go back home with is a reinforcement of what I think is important, which has to do with the last slide they presented. I totally agree with Jeff about not, I mean, being able to understand that what is happening doesn't really, is not directly always related to what you think was the cause of it. So I always quote to the reference a famous English quote, which is, it's incident to physician beyond all other men to mistake a consequence for subsequence. So I think this is very important to have in mind.
Sure. I brought support. Professor Nati Lao is a professor of psychiatry and philosophy, and maybe we can shed some light on this very complex issue, or is it complex at all?
Thank you for inviting me for this distinguished panel, Professor Clousner and Professor Gutmann. I was enriched by this your presentation and the presenter's wealth of knowledge that was shared with us this morning. In relation to your questions thus far, the first question, has it changed anything about what I'm going to do? Yes, I'll tell you in a minute. Can I predict what a person would do? Yes. To some extent. I have mistakes as well. Is it intuitive? No. It is not intuitive. Because I'm a psychiatrist, I'm a philosopher, I'm a methodologist. I wrote a book about this issue as my PhD thesis about 40 years ago in philosophy. So I believe that the hallmark of science is repeatability and not necessarily computations and evidence-based lists, etc. And the fact that we all have 5 fingers is a repeatable fact. So this is empirical. So if I can identify a repeatable behavior under certain conditions, uncertain or not uncertain, in a certain individual, that's good enough. Now let me tell you about, do I have a minute?
Sure.
Yeah, thank you. There is a popular writer who writes for the New Yorker. His name is Gladwell. I don't know how many of you read his books. There's a book about Blink.
Jeff Noy. Okay.
About Blink. Here's a book about outliers, David and Goliath and so on. I really recommend him. But one of his stories is about a Korean air company that ran into the ground 8, 10 planes, and they could not stop the disasters. Now they had to call in a TWA consultant. The consultant was like a second opinion, but he was a 100th opinion person. He came to the conclusion that they speak as a team to each other in a certain mode of subjunctive, that when a disaster approaches, the second in command finds it so frightening to tell the captain that when he tells the captain, it's a second before the crush. He had no other way to change the situation but to say, you pilots are going to speak in English. And they went through a whole training of communication in English. And we Israelis know that when we go to the States, we are different people. We are different people. When I speak in a different language, I introduce myself in a different institution. I do not believe that Tversky's approach, taking rationalism and rational decision-making on an individual basis, exhausts it all. I do not think that Weber's approach concerning modernity's boredom is a fully dimensional approach. We have a richness that goes beyond it, and it is the richness of the workshop. How can we discuss about taking and making decisions under conditions of uncertainty? Are we certain anytime? We are always uncertain. So if this is the case, then we need to understand how we modulate our uncertainty day in and day out. In the first lecture I heard here, one of the first lectures I heard yesterday, there was a discussion about how we look at cancer, breast cancer, locally and then histologically and now genetically. Were we mistaken? Of course we were mistaken. Newton was mistaken. Science is mistaken. We know we are making mistakes right now. We are far from knowing the reality. If this is the case, then one of the ways is to have us maintain the professional discussion in a professional space. Can we as individuals tolerate dispute and criticism? I've learned this in the yeshiva. To create a real interest in maintaining the space within which you promote the search for knowledge and for truth, and for this you have to have a methodology and a belief that something is above everything you as a personality desire. However, we all have personalities. So we operate in a survival mode, and we know 6 basic emotions are going to be activated. How do we deal with these 6 basic emotions? Surprise, anger, fear, depression.
Testosterone.
Depression, sometimes happiness. Can we translate them into virtues? Can we communicate with others? How do we deal with the first impressions? How do we trust our background knowledge? So what I took from this day, and here I want to conclude, please, and I learned it from the lectures, that what we take in as our background knowledge, as our memory, we create it as memory, will be activated in survival modes. But what we take in has so much to do with our personality, with the workshop we participated in, and with our teachers and colleagues. We are within one circle. So we are so different, and our personality plays a major role. Unfortunately, as a group, doctors do not pay much attention to that and prefer to put all the burden on the evidence base and methodology. If I have to predict anything, we as a group, as doctors with the evidence-based medicine, are going to run into huge problems. We need to know how to balance it within your clinical conferences. Thank you.
Thank you, Nati. Thank you. I think this entire issue is about professionalism. And the title should be professionalism. And the examples you heard, for instance, from judges that that become cruel just because they are hungry before lunchtime, applies also to physicians. Let me tell you that cesarean section rate during weekends is more than 5 times higher relative to normal weekdays. It had been published. We are influenced by major forces that we are sometimes not recognizing. And I think we have to emphasize on personality and ethics, and which combines to professionalism. Do you guys think that we have to teach that? Because we teach evidence-based data, we teach how to behave, but we don't teach how to behave under these circumstances. Or maybe it's just follow me, see me. I'm the leader, do whatever I do, or do we have to really concentrate on this topic?
So if I may, Professor Clousner, one of the things that we have instituted in our surgical curriculum is a surgical ethics course. And in fact, we have probably one of the top, if not the top, surgical ethics programs in the country. This was started initially by a medicine doctor, Dr. Mark Siegler, the McLean Center for Medical Ethics, and now Peter Angelos, who's an endocrine surgeon, is the associate director, and most of our residents and most of our surgical fellows now take a course in ethics during their research time to actually address some of these very specific issues. And then on a more frequent basis, on a monthly basis, part of our morbidity and mortality conference is actually an ethics morbidity and mortality. Because every one of these issues, I think, is very complex. I'll offer very often we do not have the answer, but I think the discussion of it is extremely important, and maybe as important as anything else we're teaching to our surgical residents, and in fact to the surgical faculty as well.
Chaim?
I think that this is something that you acquired with experience, and we have to teach. It's something that sometimes it's like when you are in the army and you are navigating, and it's called la'nos et hashetach. When you think, you see things that you in your mind, you change the reality, so that the reality combines what you expect to be. I think the most is something that you get with experience, but on the other hand, you need a peer. It's very important, it was said by Nahum. You need a peer that you can rely on, and at every point during the decision making, you had the first decision, but then you have to be questioning yourself, am I right at this point? Am I right at this point? And you always need a peer. We act as peers for our residents. We allow them to make decisions, but then we keep telling them, you're right, you're wrong, based on our experience, of course. But we ourselves, no matter how experienced you are, we also need a peer, somebody that at some points during the decision making you can rely on and to allow you to question yourself. But on the other hand, not allowing questioning all the time, you will not be able to do anything. So you need to take a pattern, but then be questioning yourself all the time.
So I was invited to make a couple of comments. So 30 years ago, I came to this country for a meeting, and I learned for the first time that laparoscopy is good to take out the gallbladder. And today I learned how wonderful this session is. I want to congratulate you for this wonderful panel, Nahum and your partner for the wonderful, wonderful presentation. 30 seconds. I'm privileged to be part of a group working with the American College of Surgeons under the leadership of Dr. Mike Czar and Dr. Sachdeva in intraoperative decision-making, which is very important for our residents and for ourselves. And I think the issue of evidence-based decision-making is relevant preoperatively and postoperatively, but the challenge we still have is making decisions intraoperatively. And I think that intraoperatively, there are two types of decision makings we make. One is strategy that can be evidence-based, but the other one is the motor skill that you learn by repetition. And the problem in learning by repetition is threefold. First of all, the lack of cases and the danger of learning by doing on a patient. Could be our sibling, could be our relative. The second is, okay, we're going to repeat with simulators. Simulators are expensive and not readily available. So what we are now trying to implement is the mental conditioning that Zullenberger had to use, because all pilots in the United States and the world that fly planes need to go through mental training. And this is something we're trying to implement now with the American College of Surgeons. It's still early stages. We're working diligently to get this started, because mental conditioning is for free. You can do it at any time to rehearse the operation you're going to do without doing it. Thank you very much, and phenomenal panel.
Thank you. I really want to thank the panel and thank the audience. I think the real challenge is to teach this professionalism and to select carefully mentors of surgery. Thank you very much.